Welcome to HMA's Vital Viewpoints on Healthcare, concise conversations with experts that identify practical solutions to make healthcare and human services work better. I'm your host, Jennifer Colamonago, and I'm thrilled to be your guide as we explore new ideas for solving challenges that confound our uniquely American systems charged with delivering health and healthcare. In a world that has far too much information and far too little wisdom, we'll aim to keep it simple. Frank conversations about what it really takes to reimagine these systems of health and healthcare. Our HMA experts know how things work and don't work, and they have viewpoints on both the problems and solutions that are born from that experience. Vital Viewpoints on Healthcare is not just another podcast. It's your window into the minds of those steering us toward a healthier future. Subscribe now, and together we will explore the hard-earned wisdom that could change the way you think about your professional challenges. Our guest today is RJ Briscione. RJ is a principal with the HMA Strategy and Transformation Practice, where he came to HMA through the focus group. Before he was at the focus group, he led social determinants of health initiatives for CVS Health, scaling strategy across the CVS Health enterprise, and previously worked in business development for Aetna, also worked with Anthem, and a stint at the Georgia House of Representatives. RJ got his degree in aeronautics from Embry-Riddle Aeronautical University, which of course is where I want to start because that makes no sense. How did you make the leap from aeronautics to healthcare?
Yeah, Jennifer, thanks for having me first. It's a very long but it's kind of fun story. I'll try to shorten it for the interest of our listeners. But all I ever wanted to do was be a Marine Corps pilot. I was accepted to Marine OCS. I had an injury that wouldn't allow me to fly. So I went the civilian route. I worked for the Delta Airlines for 10 years and got laid off from Delta during their bankruptcy. At that time, I had been doing some campaign work on the side, so kind of for fun, and decided to go into politics full time. Worked then for the Georgia House of Representatives, as you mentioned, and really to reboot the career, I assumed I was going to be a lobbyist for the rest of my life. So my first role in healthcare was as a lobbyist, as a government relations professional for Centene, which I then learned Medicaid managed care on the fly. So Medicaid managed care was new to Georgia at the time. And as I got into the role at Centene, I had great leadership there who said, you had all this experience at Delta. So Delta did a lot of varied work, actually, for everything from when I first started, really just loading bags and checking customers in, to eventually I was the writer for the pilot manuals, and did a lot of operational flight work. And then I had a lot of quality assurance, continuous improvement, Six Sigma. So the fine folks at Centene, when I was there, recognized that and said, we're going to grow you on the business side some. And one thing led to another. And here I am now. So about 15 years of mainly operational experience in health plans, some P&L leadership along the way there, and made my way to HMA via the focus group about a year and a half ago.
That is quite a journey. It makes sense, right? You sort of that Marine Corps mentality, do what needs to be done, fix what needs to be fixed, right? Which actually is probably perfect for healthcare. So your kind of noted expertise is around areas of food as medicine. I feel like this is a term that has become so common. And, 10 years ago, I was working in healthcare market research, and we started talking about food as medicine, and now it's really kind of become a reality. What was your journey to kind of realizing this idea of food as medicine and sort of the concepts around that as a strategic imperative in healthcare?
Yeah, well, a couple things really. So I'll maybe go backwards, and the transition to explain one of those transitions a little better. Transitioning from leading Medicaid business development work, which is how do we win those bids for my employer in each individual state as those RFPs are coming out? How do we continue our business? And one of a trend that I noticed, this was probably in about 2016 or 17 when the idea first sprouted, was that as plans serve at the behest of the state Medicaid department, and some state Medicaid directors were starting to ask about social determinants for the first time. And one of the really big things in social determinants that seemed sort of natural to me was food. And so I just dove in kind of headlong into that and started meeting in my business development role really with food banks to see how that would work for Medicaid members. And there was a lot of like really wanting to figure it out on both sides, but nobody really knowing what that is. The fun and exciting part of that is fast forward a couple of years down the road, here we are at HMA Strategy and Transformation. We're actually working, we have engagements kind of across the spectrum of food as medicine to really help each side. In fact, a conversation I just had with a really great strategic health plan leader said we both need to meet kind of in the middle of those community-based organizations really need to build the capacity to be able to work with health plans. And then we have to loosen our restrictions some. But to really answer the question of when I saw it was strategic is if you dive into, especially like a Medicaid population or a duals population, so 20% of Medicaid members are food insecure. So if they're food insecure, that means there's a really simple 2-question test of basically that asks, are you able to put enough food on the table, right? For your family or for your household. And so if 20% of Medicaid members are missing basic food insecurity, the problems really kind of spiral out of control from there, because then you're going for, frankly, just calories. And we know, probably anybody listening to this or interested in this work knows that Medicaid population has disproportionate amount of diabetes and congestive heart failure and a lot of things that could be food related. So I think seeing those things, the combination of some disease burden that's born from things that we think food can either be a contributing factor for or can be a preventative factor for, and the level of food insecurity made us realize that not that anything's easy, but it may be one of the easier ones to get your arms around and start doing some work on.
So, this might be a strange question, but in your years working in this area, to what extent do you see this as an income issue, an access to fresh food issue, right? We hear about food deserts
Yeah.
versus a sort of knowledge of nutrition and cooking. Like I could see all three being components. And, we sort of
Yeah.
talk about it broadly, but we don't always get to the specifics. But since you've been in the trenches kind of trying to fix the problem, I'm sure it's all of the above, but
It's all the above. Yeah.
yeah.
So yeah, there's been some great work on this. There's a great Food as Medicine coalition that I help contribute some to. That's at Tufts University, and they put together a great kind of. Everybody knows about the food pyramid. There's a Food as Medicine period, right? So the first thing is to have some population level healthy food policies and programs, right? So that begins to create some of the access. Actually, there's probably something even before that they mention in the work a lot. And this phenomenon is starting to get better, but a lot of providers really don't spend a lot of time on education on food, as they're seeing patients, because it's not on the curriculum in med school. So there's a movement afoot to change that med school curriculum to have some stringent or some additional focus on food and nutrition. Then the next level up is here's one of the things that could be a lot better, and there's been some good work around, is almost to the income question, almost universally, people who are eligible for Medicaid are likely eligible for SNAP, and then the WIC and school meals programs, right? And so there's a lot of times there's some, I won't quote the statistics 'cause I'll get them wrong, but if we just got everybody who was eligible onto those programs, which provide some real help, that would be a big boost. Then the next kind of thing up that pyramid or that kind of spectrum is there's produce prescriptions. So we've actually worked with some nonprofit clients on bringing their produce prescription to Medicaid. So being able to offer that to Medicaid health plans. Again, there's some of that. How do we connect the two things that haven't traditionally spoken to each other? And then there's medically tailored groceries, meaning we're gonna give you like a set of groceries available on a card. The card works for certain things that are authorized. And then there's the medically tailored meals, which I think is probably what most people think about when they traditionally think about food as medicine. That is, so if you're diabetic or if you have congestive heart failure, those are meals specifically designed for that specific condition. And then I think something I probably didn't mention there. There are a good number of programs, especially for those that are food insecure, that are, I don't want to demean them in any way, but that are just calories. And so I think there's a movement afoot to change those just calorie programs into higher quality meals. But of course, that all always comes with additional expense.
Well, and so that's interesting. Obviously, when you're talking about Medicaid populations, you have, a confluence, and obviously it's a means tested program. So, you're dealing with those income phenomenon. But the notion of, the medically tailored meals, increasing awareness of nutrition, all those things really can apply to any population, to any payer group. And so it seems to
Okay.
me like, there are lessons here but we're learning lessons from Medicaid on how to solve a problem that exists all over the place, maybe
Absolutely.
partially
Yeah,
in
and
Medicaid.
there's even a whole other level that I didn't get to in that, because I tend to think about my Medicaid experience. But we've seen a lot of work, and we've talked to a lot of, well, first of all, we'll back up a little bit. The whole GLP-1 phenomenon, food can be the answer to that. So talk about a cost problem. And maybe that's not necessarily limited to a Medicaid or Medicare or a duals population. That is something across the board, major cost problem, right? A lot of discussion about who's going to approve GLP-1s and what are they going to be approved for. If you take the other side of that, we see there's a lot of good solutions out there that employ food, diet, exercise, coaching that are a heck of a lot more cost effective, frankly, than a GLP-1 prescription, which when you look at it, I'm no scientist, but there's a lot of evidence of people regaining when they come off that. So it's either, hey, let's spend a little bit of time on that GLP-1, get you down to where you want to be. And then the maintenance is a long-term solution that also includes food. And then there's some really interesting higher end solutions. I shouldn't say higher end, but there's some really interesting solutions that may not fit a Medicaid plan's budget, but that might fit for that customer, for that employer-based health plan, where they want to really make a difference for their members, but that they don't want to pay for the GLP-1s for forever, right? So there's the whole spectrum there. And I think we can learn from Medicaid, especially across the spectrum, one in two, anybody across any socioeconomic is either pre-diabetic or diabetic right now, right? So that's across all populations. So I think we can learn a lot from what we've done in food and as medicine at the Medicaid, Medicare duals end to really affect kind of anybody that wants a solution for food.
So I want to ask you more about kind of the specific models that you've worked on in the past, but just in general, what is your assessment of the biggest obstacle to getting these services? I mean, I guess you could speak specifically to Medicaid, but
Yeah.
I mean, generally, you're talking about public health elements, you're talking about community health, and there's so many elements that are not really in the medical realm, and yet we know make a difference here. So, what's the biggest challenge in getting these services to people who need them?
Yeah, the biggest challenge, apart from, we could separate the logistics out a little bit. There's been some good innovation on that. The biggest challenge this is the challenge we work a lot with in strategy and transformation practice when we have clients who have great solutions for payers or for the system in general, is the whose pockets problem, is who's paying for that, and what are they paying for? Are they paying for an improvement are they paying for a pure ROI? Are they paying for an improvement in quality in one of their HEDIS measures and some of their customer satisfaction members, which again could be something really attractive to employer based. And so there's some movement on that. I'll dive into that a little bit because we've been really in the weeds on this issue right now. The probably most difficult thing in trying to fit in what most people think of as the traditional food as medicine landscape to a Medicaid, to a Medicare, to a duals plan is that most social, and this is even broader for a lot of social determinants work, is most of the anything in the social determinants realm can't fit in the medical box in that MLR calculation for health plans. And that leaves a really tough decision as a former health plan P&L leader. you're looking at in a Medicaid plan, you're looking at usually somewhere between a 1% and 3% margin. So do you want to spend all of that on a food program? To complicate that even further, the typical Medicaid member is with a health plan for 9 months. So you don't even get a full 12-month ROI kind of cost out on that if you're going to invest dollars up front. So there's some great movement on that, right? So if as people begin to understand I think the opportunity of true ROI for health related social needs, we're seeing some movement on that. So the 1115 demonstrations, I've been coached. I'm trying to get that out of my lexicon. The 1115s, everybody always calls them the waivers. They're actually 1115 demonstrations, but they're commonly known as waivers. The New York one has a path to putting all of these health related social needs in the medical line. Brand new, hasn't even started or operationalized yet, but that's really exciting. We've seen a lot of work. We've worked with clients in California in the CalAIM program, where CalAIM has carved out a loaded term in Medicaid, but CalAIM has 14 different services that are traditionally non-health that are reimbursable, right? And so we've been working with clients on how do they bring their, especially food, but other health related social need work to that program because there's reimbursement for it. So that's sort of a hybrid. It's not actually saying it's in the medical line, but there's a specific reimbursement path for it. So those are the beginnings. And we counsel clients for states that may not have an 1115 on the docket. We all know Medicaid is very well politically charged. There's an opportunity to do an in lieu of services work at the state level where you could say, hey, we're gonna do a food as medicine program. Maybe we'll start it, with just a smaller, maybe we'll start it with, I always counsel people to say, hey, we don't know where to start, we don't know where to begin. And like pick a population, go and study it and see what you come up with. A kind of a no-brainer is people who are food insecure and have higher uncontrolled A1C, just like we talked about. You can get your arms around and study that. So maybe you do that as your first in lieu of services population and start from there. So there's a path towards it becoming a little more mainstream and being able to being paid for by payers or by the public programs, but still a long way to go. And then on the higher end, people have to make the decisions or do they want to include that in benefit design? Did they want to include that as value add? Did they want to include it as part of an incentive program? One thing we haven't talked about yet is there is a really interesting model for food as medicine where it's food as engagement, meaning there's food companies that specialize in this food as engagement work with health plans, meaning the health plan has goals around HEDIS or member satisfaction or something like that, where the member gets a box of food or box of produce. And that's tied to doing some of those HEDIS measures. So postpartum visit, annual wellness checks, any of your cancer checks that are tied to HEDIS measures. And it's a really nice thing to be able to do. And it's really demonstrable in that you can show these specific HEDIS measures that we were working on that we gave people food for showed up and made an improvement. So that's something that I think wasn't originally on the table as, hey, we got to go attack a disease state. But what if we just want everybody wants Medicaid and Medicare members to be more engaged. Food to be able to do that is a really great path to do so.
So I think if I'm hearing you, you're talking about there's ROI in terms of kind of financial ROI, and then there's like measures, quality measures, ROI, if you will, right? You're getting a return on your quality measures by doing this kind of work.
Definitely. Yeah.
I'm curious what you think about, is this maybe a little provocative question, but is this the best way to spend money on the problem? Obviously
Right.
in healthcare, we know that, one person's waste is another person's income.
Sure.
And, as long as I've been in this business and we've been talking about SDOH, there's been an interesting, not a criticism, but sort of isn't this just anti-poverty, right? Isn't this something that government should just be doing through anti-poverty programs? And now, payers and health systems are footing the bill, right? So is there some sort of just like shifting onto these entities who, arguably are making money in the healthcare system to kind of give it back or pay it forward? Would this be more efficiently spent in government? I'm just curious your thoughts on this. You've been kind of worked around around all sides of the issue.
Yeah, I don't know if anything's more efficient in government, but but that aside, I think as we get closer to being able to get our arms around the true ROI, I think there's more. So true ROI is loaded answer. So I'll decouple that a bit. You can have a traditional, what I call traditional. My former boss, when I was doing a lot of this work at CVS, was chief medical officer, right? And used to that real, like, if I'm going to put this in to our operations, it's going to get me back. And again, I sort of acted as an internal consultant in that role. I had to sell some of this to those plan leaders who are the P&L leaders. That's the thing that I'd like to counsel a lot of our clients about is you are you are not selling to a broader, larger system. You're selling to individual health plans who have their own individual P&L, and it has to work for them. So for it to have to work for them, you have to bite size it down. That example I gave is a real world example. We started with dual eligible members who were both food insecure and had higher uncontrolled A1C, right? In South Florida, in partnership to get them full credit, Feeding South Florida, Feeding America, and it encompassed all of the things that you would need to make it work. Meaning there was a dietitian on site to help walk the members through, what they should be looking for themselves, a little bit of counsel, introducing some new foods, new fruits, new vegetables, how to cook those things. By the way, learned that the hard way on some other stuff earlier on, that you can't solve one social need in isolation. But we got real results relatively quickly on reducing those members' A1Cs, and that can easily translate. You can translate a reduced A1C into real dollars inside a health plan. So does it have to be health plans paying for it? Does it have to be Medicare, Medicaid paying for it? Maybe not. But I think the more of those that come back and the more evidence that's seen, the more they'll want to, or the more that could become a part of a base offering, especially for specific disease conditions or for members who have, again, there's, one of the best, I think, innovations in social determinants since I've been working on this has been that there's almost, I don't want to say there is universal because nothing's universal, but CMS has done a really good job of putting their money where their mouth is and requiring social needs screening both at the hospital. So basically every hospital in the country now has to screen for social needs, as do almost all Medicaid health plans, right? So now that we're starting to know better what those members' individual needs are and matching it with that, there's a lot of data and a lot of ability to learn from that data and get a better sense of ROI from that on how that can affect members individually and how that works for your health plan on an individual member basis.
So, right, the need to establish that ROI is really, I mean, that's business speak, but really what we're talking about is getting to outcomes, right?
Yeah.
You can give people food, but if they don't know how to cook it or they don't eat it,
Right.
or you're not going to get an outcome. So by tying it to outcomes measures, you're kind of ensuring that it's being effectively distributed or, used
Exactly
as a
right.
tool,
And
right?
yeah, and I've done a full 180 on the engagement issue that I mentioned before, because when I originally saw that, I said, well, that's not aimed at like real numbers, but it can be aimed at real numbers for things like I mentioned previously, for HEDIS results, for customer satisfaction. Imagine the uptick in customer satisfaction if you're sending your members food on a regular basis or a semi-regular basis.
So you talked about well, I'll use my words, but I think you talked about bridging the gap between organizations that are kind of set up to do this kind of work and the plan leaders, the business leaders that are selling into. So what is your advice to,
Yeah.
obviously there's so many entities, not for profits or startups that want to, be helpful, but many of them don't work in the healthcare space. So how do you
Right.
advise them in kind of making their pitch salient to the buyer here?
Yeah, well, fun, perfect, great question. And strategy and transformation group are doing exactly that right now, and we love to do that work. So there's a couple of things. One is there are always going to be basic blocking and tackling capabilities that the health plans are going to have. So you're going to have to be able to get data to them to pass their IT security and those kind of things. Now, again, I just talked to the plan leader call just before this, which was fantastic timing. He said, "Hey, we gotta work on loosening that up a little bit and making it a little bit easier." But community-based organizations have to do there's a couple paths that they could go. One, they can make decent size investment in mainly in IT type work so that there's enough data to say, we know these were this health plan's members. We know we got this to them. We got it to them on this date. They're receiving this. We're doing kind of a social care management piece for them, right? So you have to have enough technical capability to be able to do that confidently to bring that to plans. And I think the main thing that you really got to know is what those members' needs actually are and fill those needs. So not every member, not any member is going to have the exact same needs. So can a Feeding America food bank, for example, because people know those, they know to go to those, can they work on other social needs and let the plans know about that and then understand what that ROI is for that member? If that member is then going to the ER less because they're having needs fulfilled outside of the traditional healthcare system, but you have to have the data to be able to know that. And you've got to be able to get the data back and forth to the plans to be able to do that and know which members are on which plans. And then, a big piece that I think is difficult for CBOs, especially, is how do we contract with health plans, right? So health plans, I think, are doing a good job of finding easier and better ways to contract with community-based organizations. There's a lot to go there. I think one of the things I've seen is that there's some provider incentives for closing the gap on social needs now. Some plans are doing that. So there's a great way to plug in there. It doesn't have to be directly to the plan. It can be with a provider organization, meaning a hospital, a health system, a large provider organization. They're still going to run into some of those same technical pieces, but it's another opportunity. And then you see there is the tech enablement. I worked with, there's Find Help, there's Unite, who I worked with in my former work at CBS, that are creating the technical enablement for community-based organizations to be able to say who they're serving, where they're serving them, how they're doing that. And I think some of the larger ones, some of the larger national organizations are thinking about how do we do this on our own to be able to have a product, if you will, that we can bring to health plans, that we can bring to health systems to do that. So a lot of that work, we're doing some of that work here at Strategy and Transformation, which is really exciting that all of the work that's been building up over the 6 to 7 years I've been super closely tuned into this is starting to actually be able to happen and to be real, so that places like a food bank can get paid by health payers for not just for providing calories, as we talked about earlier, but for making real differences in the lives of those members.
So, in essence, a lot of these organizations that are used to serving populations, really what they have to do is to be able to individualize their work, which is not normally how, public health and CBOs
That's right.
think. They kind of think in
Yeah,
aggregate, but it seems to me that's because healthcare works in specifics, individuals, right? And so
very
it's kind
much
of
so.
tying the aggregate to the
Very much
individual,
so.
which is,
Yeah, and that's the hard part. That's not easy.
yeah,
It's
sure.
it's easy for them to serve members who they know are Medicaid recipients, but it's harder for them to break it up into the individual payers and say, we serve
Right.
this member to this payer. That there's a lot of work to be done there to make that actually work.
So, if you had a magic wand and you could apply it, what one thing would you fix in this arena to kind of have the ripple effects to create momentum in this space?
Yeah, well, I'm gonna cheat, and there's not one thing. But I think some of the momentum we talked about it. I'm focusing mainly on Medicaid, but maybe I'll pull another one. Well, we'll see where I go here. So there's a couple things, a couple magic wands. One is really that provider education, like that. Even though the basis of social determinants is that happens outside of the clinical setting. The clinical setting is still super important when you look at all the work on who do you trust most. The people trust their individual doctor. Those conversations about food and nutrition need to happen there. Something that I mentioned earlier that's really, frankly, an easy fix, and there's people doing great work on it, is maximizing all of the benefits. So if you are Medicaid eligible, you should be fully maximized on SNAP and WIC and all of any food and nutrition programs that are state based. And then the one thing that I just talked about with this health plan leader that would be a fantastic fix that is a perpetual policy wish list for people in Medicaid is to have 12-month a minimum continuous enrollment on the single Medicaid health plan. We talked about how difficult it is to demonstrate that ROI for individual members because the average tenure on a Medicaid plan is about 9 months. So if you knew you were going to have a person for a whole year, and even better if that was on some specific calendar year, that would be even better so that you know that you can invest for that member. I think that goes a long way. And then I would say on the upper end, I think I don't know what the magic wand is. I really think food has a very important role to play in this GLP-1 cost debate. Those are not going to be cheaper anytime soon until they come off patent. There's a world of difference to be made with the combination of diet, exercise, coaching, and actual food getting to that person that will help them with the specific condition. That's a bunch of magic wands.
Yeah, okay. I didn't give you 3. I gave you 1, but okay.
I know.
No, I appreciate that. It's interesting. The GLP-1 issue is interesting. I wonder if that will be kind of a gateway to a different way of paying for prevention. I mean,
Yeah.
it's acute here because of the cost of the GLP-1s. But there's so much, even when you're talking about back surgeries and knee surgery, there's so much physical kind of orthopedic work that one could argue is preventable with, exercise and mobility, all these sorts of things. And
Sure.
you sort of wonder if because is going to force the issue on cost, does this create new algorithms for, paying for prevention in a way that maybe we haven't been willing to do in the past?
Definitely. And I think we've seen that. We've seen some of the MSK solutions are thinking about that. Like, how do we incorporate social determinants broadly into our work for all of the measures that they're sort of on the hook for, or that they want to be on the hook for? How quickly are we getting folks back into the workforce or back into full mobility? And how can any of the social needs play a role in that? But food would be a great one, right? Food is a great one.
Yeah. So we talk about social determinants of health. And I think we've been conditioned to think of that as sort of poverty related, but really it's not. It's sort of, right, it's the external factors.
Yeah.
What makes you optimistic? Last question. What makes you optimistic here?
There's lots that makes me optimistic, right? There's a lot of focus on food in particular, since we've been talking a lot about that. I will say the optimistic is the screening has come a long way since I've been paying attention to this, so that we start to know what people need, and things like these 1115 demonstrations, things like North Carolina has had a very successful Healthy Opportunities pilot that they're going to expand into their 1115, where there's real dollars going to real social needs. So I think the momentum is going forward. The CalAIM is another specific, really lot of dollars going into that. So I think there's plenty of optimism in that. And then there's a lot of optimism in nutrition in general from people really wanting to get away from this. We're only treating disease and that we want to treat it preventively.
That's exciting. That does give us hope. All right. Thank you so much for being with us today and sharing your insights and for the work that you're doing. It really is impactful. So thank you so much.
Thank you. It's been very fun. Enjoyed it.
Awesome. This episode of Vital Viewpoints on Healthcare is sponsored by HMA Information Services. HMAIS is a subscription-based service that provides state-level data on publicly sponsored programs like Medicaid. From the latest managed care enrollment, market share, and financial performance data to up-to-date RFP calendars and state-by-state overviews, HMAIS has all the information you'll need to power your initiatives to success. Visit hmais.healthmanagement.com for more details. Thank you for tuning in to another enlightening episode of HMA's Vital Viewpoints on Healthcare. We hope today's discussion has sparked new insights and perspectives. To learn more about our esteemed guests, please be sure to visit healthmanagement.com/podcast. Until next time, stay informed, stay curious, and keep searching for the wisdom that will help to transform our healthcare landscape. This podcast was produced by myself, Jennifer Colomanico, along with Tiffany McKenzie, in collaboration with our guests. The content is the property of Health Management Associates.